Live. Good morning, everyone, and welcome to a new appointment organized by the International Society of Coronary Artery Surgery and the International Coronary Congress of this live talk appointment. Appointment that with a monthly, generally, timeline, trying to bring together a group of colleagues and friends around a topic of coronary artery bypass grafting. These events were originally started during COVID time to try to create a community. And then we discovered that ICC and ISCAS wanted to be more than one yearly meeting appointment, but wants to be a community of people that are aimed to learn together, to try to understand literature, scientific literature, people that are passionate about coronary artery bypass grafting and wants to take care of their patients Monday morning with changing their practice, changing and learning something new on a Saturday, talking with some colleagues in front of a cup of coffee. And so with this aim, we have organized today a new appointment entitled Off Pump versus On Pump, one of the eternal debate of coronary artery bypass grafting that today have some new evidence. And we will try to understand what is the current role of off pump. This event has been supported by Medtronic, that has very generously always supported International Coronary Congress and ISCAS. And together with me today, I have three fantastic speakers, Dr. André Lamy from McMaster University, that will review the long-term results of the landmark randomized controlled trial that profoundly influenced the perception and the adoption of off-pump 20 years ago. Dr. John Pascas from Emory University that will present the contemporary analysis from more than 1 million patients from the STS cardiac surgical database. And Mr. Shazad Raja from Royal Brampton and Airfield Hospital that will share the long-term clinical outcomes and clinical practice lesson from one of the world's leading dedicated off-pump bypass surgeon. So with any further ado, I want to start the conversation, and I want to remember everyone about the new appointment in New Delhi for this year in November, from the 20 to the 22nd of November for International Coronary Congress. So I'll give the microphone to André. André, please.
Yes, good morning. Thank you for having me. So I will show you some slides that I presented at the STS meeting in January in New Orleans. So it's a meta-analysis of the three main trials, so Ruby, Coronary, and GovCape. You wonder why would we do that? I mean, the results are published and we cannot add up the numbers, but the interest is to join the databases together so that we can analyze the data better and mostly analyze the results in function of the risk of the patient or the surgery. So the first step was to put these numbers together. I'll present that. And then the second step, hopefully will come one day, is actually to do the analysis according to the risk of the patient using either Euroscore or STS. So the outcomes at 30 days of these three big trials, so it's almost 10,000 patients. And you can see there the composite of death, MI, revascularization, and stroke. 8.4% off pump, 8.0 on pump, and the relative risk of 1.03, and it's not significant. So basically dead neutral. And for you see the results for death, MI, and stroke, and they're about the same except for revascularization. The 0.9 versus 0.3%, so a small difference, but it's statistically significant between the two groups. So now at 5 years, we have the results and they're about the same. Again, the risk is 1.04. It's not significant. And the mortality is borderline in revascularization. It's still significant at 0.05. So it's a small difference of 0.7, 0.8% that carried on since the day of the surgery until the end of 5 years. And what about we look at the patient who are converted and non-converted? Well, why that is because when you operate, you're not under a protocol, right? You look at the patient, and if you have to change your decision, you change your decision. Like either you go off pump, or you go on pump, or whatever, because you adapt to your patient. It's not like that in a trial. The trial, they're ITT, so you intention to treat. So if you analyze the patient, if the patient is randomized off pump and you decide to go on pump, well, the results still go with the off pump group. So that's what we call ITT. But if we decide to exclude the patient who were converted, and we do what we call a protocol analysis, like basically how it happened, then you can see that these no converted patient, they're pretty similar. Like you, off pump is slightly better, 0.99, and you can see that the results are very comparable, except for revascularization again, and we see that. And the next slide. Now the converted patient. So basically, there's an interesting story here. So first of all, if you convert off pump to on pump, the composite is much higher. It's significant. It's very high. It's double. And is it because the surgeon converted too late? Probably. Because the surgeons in the trial, they were under pressure to deliver. Like if they're converted off pump, you stay off pump. And I was there to remind them. They were checked, they were followed, and some surgeons were excluded if they were not doing the right thing. So those who were converted didn't do very well. But those who were on pump that got converted to off pump, they did much better. And I want to bring down to the stroke result, 0.4%. So these patients, the main reason to switch these patients is calcified aorta. But despite the calcified aorta, you have the lowest risk of stroke ever seen. Why? Because these surgeons were off pump and on pump surgeons. When they saw a calcified aorta, they just adjusted their technique. Either they went anaortic or they changed their grafts or whatever, and they got a very low rate of stroke, 0.4%. With calcified aorta. This is remarkable. Never seen that before. So these are, I'll show you, let's show the Canadian, because I don't have only a few minutes. The Canadian results. So if you take coronary, my trial, but only Canadian patient, we got 822 patients. And well, the results are different. So off pump, you get 8.8, on pump, 13.5. And the difference is, I mean, you have a 40% reduction in risk. This is huge. And it is significant, 0.02. And the risk reduction, which is very interesting, is the risk reduction hazard ratio is constant. If you go for CV death, stroke, non-fatal MI, and new renal failure, it's 0.6, 0.7, 0.4. So it's constant. So it shows that at 30 days, off pump is very superior to on pump. And these are the Canadian results. So these are the results from my colleagues in Canada. And I use my feeling of at that time to design the coronary trial. And my last slide at 5 years, well, these results are holding. So for the composite outcome, 15.5, 21%, and it's still a difference of 0.02. And the hazard ratio is basically hasn't changed over 5 years. So in Canada, in the coronary trial, off pump is clearly superior to on pump. Why? Well, probably because we're better surgeons? Nah, not at all. Because it's a matter of surgical risk. The patient will benefit from off pump, a patient will get higher risk, not lower risk. You need to be at risk of a complication for off pump to deliver its benefit. As simple as that. Coronary was much higher risk than Ruby, for example. That's why we have different results. And within coronary, you can see that these results are the same. In South America, the results are even better because their patients were higher risk. Same thing in Europe. Where we lost the benefit in coronary is when we went to China and India. Not because they're bad surgeons, just that their patients were so low high risk in these countries that it diluted the overall effect of coronary end up being a neutral trial. But in higher risk patient, or in Canada, it's very positive. I'll stop on that. Thank you.
Fantastic. Andre, first of all, congratulations. I must admit that as a surgeon with interest in coronaries, I always admire every time you speak at one of the congress. It's and I say very genuinely, I literally like it's just remarkable to see such an academician, a surgeon who dedicated his life not only to surgery but also to science. And we all know that taking a position like this in life is never easy because you have a busy practice, but you have a busy research activities, and some people cannot see you as a research and not see you as a surgeon. So there's a lot. You're always in between two fried pan. So congratulations. Was very, very interesting, and I think that you touch a lot of the point of conversation that we want to have here. So next, Dr. John Pascas, we go through all of the presentation. I think that it is nice to put all of the data out and then try to draw in some conclusion. Dr. Pascas, you are going to share your presentation?
I'm trying. Here we go.
If you want to do share, there is the share button down there, and you should be able to.
Do you see it?
No.
Okay, then let's switch immediately.
Let's go like
you
this.
do it, okay?
Yeah.
Super. So this, like Andre's excellent presentation, this next presentation was delivered also at the recent STS meeting. And this is the product of work from a large number of people, just as Andre led an outstanding team in Canada to conduct the coronary trial, and frankly deserves a huge amount of credit for doing so. I had the privilege of participating in this research effort with this group of people you see on the screen, especially Robert Habib, who's the PhD biostatistician employed full-time by the STS to analyze the STS database. He really did the lion's share of this work. We sought, and these are our disclosures, we sought to understand the relative benefit of off-pump and on-pump surgery within the STS database. And as we all know, there have been numerous retrospective and prospective studies that have focused mostly on 30-day outcomes. And indeed, the STS database has published previous papers related to 30-day outcomes. But what we didn't have was good data on longer-term outcomes from the STS database. And of course, there's been a lot of concern, and the conversation we had just moments ago touched on this, the question of how capable and experienced are surgeons with these two alternative techniques. Is an on-pump operation just simply easier to do and therefore more generalizable than an off-pump operation? And do we have the right patients? Are they high risk enough to benefit from off-pump surgery? And the right surgeons, are they capable of doing either operation, involved in randomized trials, or for that matter, in retrospective studies? So we felt that surgeon experience was very important. As I mentioned, there have been multiple previous studies. Go back one slide if you would, Gianluca. Multiple previous studies have looked at 30-day outcomes within the STS database and demonstrated much better outcomes for off-pump than for on-pump for people at higher risk. And those include female patients, those with lower ejection fraction, and those with higher predicted risk of mortality according to the STS predicted risk algorithm. But only very recently has the STS database been linked to long-term follow-up. And that's been done through access to the U.S. National Death Index and the Center for Medicare and Medicaid Services, so that for the very first time, we're able to ask the question, within the STS database, what are the long-term outcomes of off-pump and on-pump, and how do they compare? Next slide. Thank you. So that was our aim, to look at especially intermediate and late outcomes for off-pump versus on-pump overall, and also stratified by the extent of coronary disease. Is complexity of coronary anatomy a prime driver for the relative benefit of one or the other technique? We also wanted to go back and look at the short-term outcomes and also be able to show what are the longer-term trends in adoption of off-pump bypass over the last 2 decades. So this is the consort flow diagram, if you will. We began with over 2 million isolated coronary bypass operations, excluded about 500,000 because we couldn't get them linked for one reason or another to long-term follow-up, and excluded also patients who'd had previous coronary bypass or were salvage cases or had unusual operations like left heart bypass. Hybrid operations, which were intentionally designed to be hybrid, were excluded. And so that left us with about 2 million isolated coronary bypasses. That broke down into about 200. It's a little difficult for me to see those numbers just now, but about 200,000 intention to treat off-pump bypasses. And then what we did was this greedy 1-to-1 propensity matching, which generated about 184,000 pairs of propensity matched patients. Within each pair was one patient who had off pump and one patient who had on pump, and they were matched for 64 preoperative variables within the STS database. And that is really a remarkable achievement, a huge amount of statistical work within this giant data set. And again, that's the credit goes to Robert Habib for doing that. Importantly, we analyzed the off-pump patients by intention to treat. That's to say, off-pump patients who underwent an unplanned conversion to on-pump were included in the off-pump group for all analyses. This is an ITT analysis. Now, what we wanted to do was also identify experienced surgeons. And so we sought among our group of authors an agreeable or agreed upon definition of what would make a surgeon experienced. Because of course we use experience, a number of cases really, as a surrogate for expertise, because we can't measure expertise. And we decided that a surgeon, in order to be involved in this study, would have to have done at least 200 cases during this very long, more than 15-year period of enrollment. So it's not a large amount, but that would be just 25 cases per year as a minimum. And so again, that's, 2 cases a month. It would have to have been active for 3 years. And to be an experienced off-pump surgeon, we felt that they should do at least 40% of their cases off-pump. And an experienced on-pump surgeon would typically do the large majority of their cases on-pump. We wanted to compare operations or outcomes for patients who were operated by truly experienced off-pump surgeons compared to truly experienced on-pump surgeons. This group of patients would be operated by surgeons who were in their comfort zone. And we created those definitions, and then we confirmed that there were enough patients in the STS database to allow us to do the analyses with these definitions, and only then did we look at the outcomes. This was not a fishing expedition to try to find the right definition for experience to get one result or another result in the analysis. We did this in a very stepwise fashion. The primary endpoint is all-cause mortality, because that's what the follow-up allows us to do, only all-cause mortality. Now, but for interest, you can see that off-pump bypass has actually declined in utilization over the United States, going from roughly 20% at its peak to roughly 10% now. So a relative 50% decline over this 15 or 17 years of analysis. And this just shows you that the experienced on-pump and experienced off-pump surgeons lived in their respective zones and indeed did, for the bulk of their cases, on-pump or off-pump surgery. And for perspective, we first looked at all the cases in the STS database. So this is not propensity matched. This is not those intention to treat analyses. This is just raw outcomes for all patients on or off pump. And you can see that the lines almost overlap. There is no significant difference. The adjusted hazard ratio is slightly in favor of off pump, but it's not statistically significant. I think even saying that is incorrect. These lines are overlapped. And now we're looking just at the experienced surgeons, those 184,550 pairs of propensity match patients based on 64 risk factors. And these are the outcomes in the perioperative period. So this is 30-day data. What we previously was all we could get from the STS. And like all the previous analyses of the STS database, it shows an advantage for off-pump bypass in essentially every endpoint that we looked at. Off-pump was at least slightly better than on-pump for mortality, morbidity mortality, stroke, renal failure. The only difference that wasn't significant was deep sternal wound infection. And essentially all these others, the p-value is less than 0.05. In fact, in most cases, much, much less than 0.01 for all of these, just due to the huge sample size. And interestingly, you'll see there's a difference in terms of what surgeons actually did in off-pump and on-pump operations. This touches on one of the points that Andre Lemay made, the issue of incomplete revascularization, which was more common in off-pump surgery, and arterial grafting, which was also more common in off-pump surgery. Transfusion being one of those things that most dramatically favored the off-pump group. Next slide, please. Thank you. And this is broken down by 1, 2, or 3 vessel disease and repeats all of those numbers, but basically it shows the same thing for each of those extents of coronary disease. So here's the take-home message. This is long-term survival in propensity-matched patients, 184,550 pairs, and the data are just absolutely overlapping. And when Robert Habib, the statistician, showed me this for the first time, I said, is this a mistake? Have you got a problem with your program? How can this possibly be so identical? He said, I checked it 3 times. This is what it is. It's hard to imagine a more identical long-term survival. So that among experienced surgeons in the STS database performing 184,000 pairs of operations, either off-pump or on-pump, outcomes over 15 years for the single endpoint of survival are literally identical. And here, if you break it down by 1, 2, or 3 vessel disease, again, there's no significant difference, except that in the 1 vessel disease patients, there's an advantage for off-pump bypass. So if you're going to have a 1 vessel operation, you're better off off-pump than on. And most of these are Lima LEDs, which are performed very routinely, and avoiding the heart-lung machine and aortic manipulation for that group of patients is a clear advantage. They are a minority of patients in the STS database, of course. And this is again among the propensity matched patients. You can see the relative benefit is mostly in 1 vessel disease, not so much in 2 or 3. And interestingly, we looked here in this as age, cohorts of patients that were young, intermediate, and older. And the relative benefit of off-pump or on-pump was more impacted by extent of disease than by patient age. Now, this is the thing that I actually found most interesting about this analysis. Because the incomplete revascularization, which Andre pointed out earlier in the combined prospective randomized trials, was also seen exactly as in that group of patients that he studied, was also seen in this STS database analysis. There was about 0.22 fewer grafts in the off-pump patient than in the on-pump patient in the STS database. And interestingly, multi-arterial grafting was more favored by off-pump surgeons, and off-pump patients received 0.1 more arterial grafts than on-pump patients. And one might anticipate that less complete revascularization would shorten life, and more arterial grafts should lengthen life. And then the question was, to what extent? Next slide, please. And here are the hazard ratios by Cox regression for incomplete revascularization and multi-arterial grafting. For patients who had more than 1 arterial graft, the hazard ratio of death was reduced by 40% compared to a similar patient who received a single arterial graft. And this is over 15 years of follow-up. Similarly, incomplete revascularization was associated with an increased risk of death of 1.33. You notice that those are almost reciprocals of each other. And so I thought this was a very important effort. I congratulate Joe Sabic, president of the STS at the time that this study was authorized and funded. It cost a lot of money. It takes resources to do this. So I thank and congratulate him for making it happen. We found clearly that over long-term follow-up, off-pump and on-pump have very similar results. Both can provide excellent outcomes. Perioperative morbidity and mortality are significantly reduced in off-pump patients, but that early survival advantage diminished during the first 5 years, perhaps due to more incomplete revascularization with off-pump, but was later mitigated by slightly more multi-arterial grafting, so that at the end of the day, over 15 years of follow-up, the curves literally overlap each other. Next, last slide. And I take a little step forward in terms of interpreting these. I think this emphasizes the importance of complete revascularization, precise revascularization, and the use of multiple arterial grafts to improve outcomes for all patients having coronary surgery, whether it's on pump or off pump. And I think that this points to the fact that coronary surgery is a challenging operation. We feel that it should be recognized as a subspecialty within adult cardiac surgery and is worthy of special training and requires special expertise to really get the best possible outcomes for our patients.
Fantastic. Dr. Pascas, thank you so much. This was a great presentation, and most importantly, I think also highlight one of the very important new trend in science around cardiac surgery, the fact that we cannot limit ourselves to the 30 days outcomes of what we do. And this is true for a Ross procedure, for a coronary bypass grafting, or for a AVR versus TAVR. It's tough to say what is the best choices when you just count the 1 year outcomes. So this type of study, as you pointed out, are extremely expensive, very complicated to make them happen, but so important to dictate what is the long term. When we consent a patient in our office, what can we talk to him about, what we can share with him about the 10 years, the 15, the 20 years outcomes of the procedure that we are planning to do. So I give the microphone to Shahzad, and I really will, I'm looking forward to hear your experience as an active practice surgeon and big lover of off-pump. Shahzad, you passed through all of these phases, the phases of enthusiasm, and then the phases in which everybody was telling you why you are performing off-pump. That's dangerous. And you just recently came up with this paper here on the left, on the right, sorry, on anal thoracic surgery about your 25 years outcome. So looking forward to your presentation.
Thank you very much, Gianluca. I think, thank you for the invitation. And I think Dr. Lemay and Dr. Pascas have already given us two of the most important perspectives on this debate. I mean, we've heard the evidence from the landmark trials, and we've seen what contemporary real-world practice involving more than 1 million patients looks like. I think I'd like to take the discussion one step further by exploring what long-term experience tells us when the technique is applied consistently within dedicated programs, why adoption remains so variable around the world, and last but not the least, why preserving expertise in beating heart surgery may be even more important for the future than for the present. So you've thankfully showed the first slide. I think I would like to begin with two complementary pieces of evidence from our group examining the long-term impact of off-pump surgery. On the left side, we have a meta-analysis, which is an updated meta-analysis looking at 22 studies with almost 70,000 patients. And at 10 years, what is interesting here is that the mortality was identical for the two strategies, for off-pump and on-pump, with a pooled hazard ratio of exactly 1. What is more importantly interesting is that when we did the meta-regression, it suggested that increasing age and comorbidity burden may actually favor off-pump approach, something that we've already seen from the data that Dr. Lemay and Dr. Pascas have presented. So what does this meta-analysis tell us? The population level message is therefore reassuring. When patients are appropriately selected and surgery is performed by experienced surgeons, off-pump CABG does not compromise long-term survival, something which has been a long-time perception or misperception, whichever group you belong to. We have recently examined our 25 years institutional experience. It's actually more than 25 years. We looked at our revasc cohort of 14,000 patients. We did one-to-one propensity matching, and we compared 5,684 off-pump patients with an equal number of on-pump patients. The purpose of the study was predominantly to look at the impact on long-term survival. And as you can see here, the survival curves gradually separated over the long-term follow-up, with a 25-year survival of 57% for op-cap patients compared with 42% for on-cap patients. And I think this is a message that we're more likely to see when Dr. Puskas and his colleagues look at their million patients, perhaps 5 years down the line. I think the curves will definitely start to diverge in that cohort of patients as well. I think my explanation for this divergence and for this benefit of op-cap is very simple. We are a center where we treat all comers with op-cap. And if you are not selecting just the high-risk patients for op-cap, you're likely to see this sort of results. We offer op-cap to every patient. And I think if you're offering it to your younger cohort, you're likely to see this improvement in long-term survival, both statistically as well as clinically. These findings are not contradictory. If you ask me, the meta-analysis established the long-term safety of op-cap across a heterogeneous population, whereas our institutional study demonstrated that what may be achievable when the operation is delivered consistently within an experienced high-volume program. Together, I think they move the debate away from whether op-cap works or not. I think the more important question becomes under what circumstances, for which patients, and in which hands does it deliver additional value. So naturally, this will lead us to the next question. If the long-term evidence is reassuring, what does the contemporary practice looks like? And I think, again, on the left side, you can see that op-cap is not a disappearing procedure. I mean, the bar chart basically shows the volume of CABG procedures performed in 2025. And it's very clear that a fifth of the CABG volume is actually off-pump. However, at the same time, I think the adoption varies dramatically. If you look at the graph and the map, from approximately 56% in Asia to around 15 to 20% in Europe and North America, and only 5% in Australia. I think this difference cannot be explained purely on the basis of pattern of coronary artery disease. I think this can predominantly be explained on the basis of the barriers to the universal adoption, which I have shown on the right side of this slide. They largely reflect differences in surgical culture. They also are probably a result of focus on training or no focus on training in op-cap, institutional commitment, and program experience. All these barriers are actually interconnected. I mean, op-cap is technically demanding because of exposure, because of coronary stabilization. We all know that in hemodynamic management. All of these things occur simultaneously, and that inevitably creates a steep learning curve. We've all gone through our steep learning curves, and we very well know that when trainees have limited exposure or experience mentorship, op-cap does not thrive. Concerns regarding completeness of revascularization and long-term graft patency, in my opinion, remain entirely legitimate. I think if somebody says that these concerns do not exist, I think they are fooling themselves. However, I think I'm a big believer, and I think I've learned it from Dr. Puskas, that avoiding cardiopulmonary bypass can never justify fewer grafts or lower quality anastomosis. I think if you're not trained, if you're not experienced, do not compromise the quality of your anastomosis or the number of grafts purely for the sake of performing a less than optimal op-cap procedure. We've learned over the last almost 30 years that successful op-cap is a team game. You require experienced anesthetists. You need appropriate stabilization technology. You need coordinated theater staff, and you need to have robust protocols for safe conversion when necessary. Finally, I think what has not helped is the uncertainty in guideline recommendations and patient selection. continues to discourage the broader adoption of OPCAB. My view is OPCAB is well established globally, but universal adoption is neither realistic nor necessary. I think safe expansion will depend on expertise, program infrastructure, and careful patient selection. And I think most importantly, my view is it's for a select few surgeons, what Dr. Puskas has already mentioned as specialist coronary surgeon. I think we need to have specialist coronary surgeon in the future for us to ensure that OPCAB persists, survives, and thrives. So obviously, moving to the final slide, rather than, in my opinion, rather than asking how many surgeons perform OPCAB today, perhaps we should ask a different question. What future capabilities do we risk losing if expertise in OPCAB disappears? And I think, it should not, OPCAB should not be simply viewed as conventional CABG performed without cardiopulmonary bypass. In my opinion, it is the enabling platform for many of the most important advances of contemporary coronary surgery. Mastering beating heart exposure, stabilization, and hemodynamic management provides technical foundations for anaortic CABG, where both cardiopulmonary bypass and manipulation of the ascending aorta can be avoided. And the same skills underpin minimally invasive and robotic coronary revascularization. I think these developments would naturally converge with total arterial coronary artery bypass grafting to maximize long-term durability. And taken together, I think they suggest an ambitious but compelling vision. I think my vision, and I think that of most of us on this call today, is the holy grail of coronary surgery, which will be robotic anaortic total arterial off-pump CABG. I think it combines minimal invasiveness, neurological protection, and durable revascularization. And again, this is not an operation in 2026 for every patient or every surgeon, but I think it's an aspiration for expert programs with specialist coronary surgeons. I strongly believe that in order for us to achieve this holy grail, we would need to follow what we in our institution call as the 10 commandments of OPCAB. And again, I mean, these are a framework for making expert OPCAB safe, reproducible, with consistent, excellent outcomes. So perhaps the question is no longer whether every surgeon should perform OPCAB. I think the more important question is whether specialty can afford to lose the expertise that make the next generation of coronary surgery possible. I think OPCAB does not need to become universal, but the capability must remain available because it is a bridge to least invasive, least manipulative, and potentially more durable future of surgical coronary vascularization. Thank you.
What a great presentation. I think that it was the perfect final slides and final comment that is the 30,000 feet view of all of these half hour that we just witnessed. So Shahzad, fantastic. Really, really thank you for this. And my taking home a message here as someone who is exactly in this direction. I because of my interest in robotic, I get a lot of phone calls and a lot of emails from colleagues that wants to be involved or want to start a robotic coronary program. And my first question all the time when I talk with these friends and colleagues is, how do you perform your CABG when you have a regular coronary artery bypass grafting that you are approaching via sternotomy? What type of techniques? And I can tell you that taking someone that only knows how to cross-clamp the aorta and give one mammary and two veins to a patient to a robotic whatever, mid-CABG, T-CAB, BIMA, T-CAB, it's, I don't want to say impossible, but it's extremely more challenging. It's difficult to advance the field and introduce more technical, complex procedures if your baseline, if you have never sewn before a lima to the LAD, via off-pump, via sternotomy, it's very difficult that the first one you do it through a small incision, through a thoracotomy. So as you were saying, the enabling opportunity, the platform that allows. On the other side, I would say that unfortunately, when you speak And when, like, I believe that most of the cardiac surgeon, if you interview them, they believe that off pump is an inferior way of performing bypass grafting. That's what the perception around there. So, Andre, I'll give you the microphone and then ask you how we change this type of, like, first of all, should we change? Is it true? Can we have seen these outcomes, we have seen these results, we have seen these slides. How can we change this culture, this stigma of off pump being something bad for the patient, that increase mortality, doesn't complete the revascularization, and it's something that shouldn't be performed? How can we change the perception among us cardiac surgeons, first of all?
That's a good question. I think that John's and Shahzad's presentation actually will help. Personally, I didn't know about STS having a long-term follow-up, and the results are extremely good. I mean, it's there. I think the way to change the perception of people is to look at what is your patient at risk, which complication do you expect on your patient, and if your patient is young and healthy, I mean, don't worry. Just do it on pump and don't worry about it. But if your patient is older, has kidney dysfunction, has diabetes, may have calcified aorta or not, these patients, you have all sorts of complications and you have to target, you have to adapt your surgery to your patient. But again, if you know only one way to do the surgery, well, it's everything is a nail. All you have is a hammer, right? But if you have both techniques or mix of these techniques, then you adapt yourself to your patient, to the benefit of your patient, not your own benefit. So I think that's the way of thinking, and that we have to tell in our residents. We have to, I was doing that with my residents. I was a Royal College examiner for many years. It's same exam as in the States or in the Kingdom. And my favorite question is like, well, you're on call today, you patient, and open the chest and the aorta is calcified. What do you do? I said, well, I call in older colleagues. Well, today is a golf tournament of the hospital. They all gone. You're alone. What do you do? Well, if you see a resident that's been trained off pump and on pump, then, well, I can do this, I can do that. I can, patient is unstable. Well, I can cannulate the axillary artery, go on pump, blah, blah, not cross clamp and do so they know, they think differently. So I think it's a high level of surgical intelligence. They're all intelligent people, but I think you're just thinking a little bit higher up about what you're going to do in the OR and why you're doing it. And that's probably why these surgeons actually are using more arterial conduit, because they have a higher surgical intelligence. They're thinking more and more about what they're doing in the OR and what can benefit their patient. So that's my vision.
I completely agree. No, you're exactly. Is the taking home message that we saw from the slide of Dr. Pascas. The surgeon, and it is true also in my observation, the surgeon who does off pump is more keen to perform also more multi-arterial bypass grafting. And this is a reflection that most likely someone that does off pump is more keen to consider coronary artery bypass grafting as their own super specialization, their own niche of interest. These are surgeons who takes a bypass not as, oh my God, I have another bypass to do and it's 4 p.m. and just open, give him a mammoth and 2 vein. I just want to go home. But taking that patients with the care and attention that reserve, and offering no-touch aorta and radial and BIMA and the different type of strategy. But so, Dr. Pascas, how we change this? Like we now are seeing that effectively in subset of patients that are deep down, the patients that we most likely come and see us as patients that are the sicker, the patients with diabetes, the patients with slightly low ejection fraction, off pump as an opportunity. And this off pump is also a great opportunity for blood transfusion, for enabling risk-free, stroke-free type of surgery. But it's difficult to get there if the only time you perform it is in very selected patients. How can we start to train the next generation of surgeons? How can we shift the culture around off pump among us? How can we really create a generation of dedicated coronary specialists?
Thank you, Gianluca. I do think we're going to have to have coronary surgical specialists trained to be coronary surgical specialists. Andre and Shahzada both commented on the importance of training programs, and those will only exist at centers that have dedicated coronary off-pump practices. And as Dr. Raja said, an institutional commitment to it longitudinally over time so that the techniques become part of the culture. That means that an individual who spent a year with Dr. Raja would leave that whole system in their mind and able to go forward with what Dr. Lamé described as higher surgical intelligence. I like that expression. To contemplate being able to do that kind of operation, because as was pointed out, off-pump bypass is in an important way a foundational tool to build the next more complex, less invasive, more durable kinds of surgical coronary revascularization. And without that foundation, I don't think we're going to get very many practitioners to that ultimate goal. We need to advance the field step by step, not taking giant leaps. I would love to see coronary surgeons globally simply adopt a second arterial conduit for every patient. That should be the default. 2 arteries and the rest vein. On pump, single clamp. Do exactly what you're used to doing, but add 1 graft and make that the norm, the baseline. That graft can be a right mammary or a radial. It's frankly easier for surgeons to adopt the radial. But that would be a stepwise approach that moves the field forward and benefits a large number of patients with very little risk of imprecise or imperfect or incomplete revascularization. And then I think, again, we need to expand the number of dedicated training programs for coronary surgery. We offer one at Emory. I'm looking forward to welcoming our next fellow. He'll be joining us next week. A graduate of an I6 program in the United States and board eligible, who will dedicate an extra year of his life, accepting another year of resident salary rather than an attending salary, in order that when he finishes, he will be really a skilled, focused, dedicated coronary surgeon. But I'm producing those people one at a time. We need dozens or hundreds of them produced. So we need other programs that have institutional experience in off-pump bypass to create those training programs. We need the leaders of our biggest, oldest societies to recognize that that's important and, give credibility to it, approval to it, encouragement to it, so that we will begin to create some of these specialists. I mean, it wasn't very long ago that there was no such thing as an aortic specialist. It wasn't long ago that there was no such thing as a mitral repair specialist, but those things are now considered commonplace and necessary in big institutions. For goodness sakes, the mitral valve, when you're putting stitches in the mitral valve, the margin for error is greater than the diameter of a coronary artery. I mean, we are doing a much more technically demanding operation, the mitral repair, and yet somehow that is recognized as something requiring special expertise, and coronary surgery is something that everyone can do asleep. And that's not rational, and it's not in the best interest of our patients. I think, we really be taking the highest risk patients at institutions that have a skilled off-pump surgeon and reassigning them to that off-pump surgeon. Because as Dr. Lamé pointed out, and as we've seen from the STS database, patients with the highest measurable preoperative risk for a complication on pump have the greatest benefit of avoiding the heart-lung machine. And finally, I'll say, my practice has evolved to being a routine, all-arterial, no aortic touch off-pump bypass in these last 5 years. We've done 1,000 of those operations now. It is not trivial. It is a technically demanding operation. Some days it's very demanding. And it's not for everybody. It's not for every patient. It's not for every surgeon. But when we can do it well in the right patient, the outcomes are spectacular. They're really remarkable. And so that holy grail that Dr. Raja commented on, I think it's worth striving towards, but we should do so in a stepwise way, systematically, identifying which patients are really going to benefit. This is not some sort of, close your eyes and leap kind of a thing. We've got to do this wide open, step by step forward.
Yeah. So, Dr. Pascas, just because you are here and we go to Shazad, but there is this, we are receiving a lot of interesting questions from online. And there is this very interesting, I want to say thanks to Philippe, who is watching us. And it's interesting. Let's take a little bit further step in this analysis of incomplete revascularization, total arterial revascularization. Actually, let me start with Shazad. Tell me your taking home message of this incomplete revascularization and total arterial revascularization. Is this really what probably is more important than the discussion of off pump versus on pump? Is more the type of conduit and how many conduit that we give rather than the technique that we use?
So, Gianluca, I think, the first and the foremost thing of importance is that your patient should leave the OR alive. I think that's the most important thing, okay? Everything else follows. And I'm a big believer that you could do the most fantastic operation where the patient leaves the OR in a box. None of you have achieved anything, So, but at the same time, I think, I'm also a big believer that if you take somebody to OR and you do a half-cooked, half-baked job, your patient is more likely to leave in a box. Unfortunately, in coronary surgery, the room for error, as Dr. Pascas mentioned, is in millimeters. And I teach my residents and trainees, every suture or every stitch is $1 million stitch. If you don't put it right, you end up paying the price, both you and the patient. Patient obviously pays a much bigger price, but you're not going to be left alone by the lawyers and the solicitors on behalf of the patients. I think all of these things are extremely important, and that is why I think I'm also a big believer that coronary surgery is a specialist procedure. If you're a coronary surgeon, you are going to strive to do multiple arterial grafting. You are going to strive to avoid cross-clamping the aorta, and you will make sure that you lift the heart and revascularize the OM and not leave it because you're not competent enough to do that. I think in 2026, if you claim that you're an off-pump surgeon and you're scared to revascularize the lateral wall of the heart, you're not an off-pump surgeon and you're not being properly trained. And I think it's very worrying. I know that a lot of us have the default of a clever cardiologist in the cath lab who's going to bail me out, but the patient is not paying you to do a half-cooked, half-baked operation unless there's an agreement at the time of signing the consent form that we're going to do a hybrid procedure. I think hybrid, again, is sometimes not necessarily used in the right way. So incomplete revascularization is a legitimate concern. And I think in 2026, no off-pump surgeon should, knowingly undergraft a patient. I think arterial grafting is something that we should all, multiple arterial grafting is what we should all be striving for. I think nobody should leave the operating theater if they are a good specimen with at least with two arterial grafts. That's my standard practice. I mean, we are a big user of bilateral IMAs in our institution. I think it's a default operation. I think we combine off pump with bilateral IMAs and we get very good results. I think one of the key reasons why I think the curves start to diverge in our institution is predominantly because we are very arterial graft heavy institution. I think almost 50% of our patients would end up having two arterial grafts, and I think 70% of us off-pump surgeons would give our patients multiple arterial grafting. So I think that's a reflection. Those results are a reflection of our institution practice. But at the same time, I think I'd agree with what Dr. Pascas and Dr. Lemmy said. Off-pump is not for everyone. I think you need to be trained 12 months in a dedicated program, and I've done that over the years. I take exactly the same as Dr. Pascas does, one resident for a year, and I teach them starting from diagonal grafting all the way to 3 to 4 grafts off pump, in a systematic manner. They all leave the program. I have my current fellow at the moment who's a very experienced aortic surgeon, but wanted to do coronary surgery. And I can tell you, it's a joy and it's a pleasure to have somebody who's experienced, because you don't have to teach them the basics. You can sometimes take them to the advanced, stages. And I think, that's the way forward. I think I'm also a big believer that ESCAS and ICC are in a privileged position to push for recognition of coronary surgery as a subspecialization. We need to have a curriculum. We need to have a standardized program. And I think we need to have, as Pastor said, more surgeons training more future surgeons. And I think, funny enough, I don't know if you would agree with me or not, but I think the push for robotic surgery is probably going to be the single most important reason why there will be an uptake of off-pump in the next 5 to 10 years. I think it's strange. It should have been the other way around, but I think, robotic is probably going to push for OpCab, and I think we are already seeing that. I think from my personal perspective, it's always very reassuring when you get a phone call from a patient saying, "Doctor, do you do aortic CABG? And I would like to have 2, if possible, 3 arterial grafts." And I, see one of these patients pretty much every week, which is for me, a very reassuring thing as an off-pump surgeon, as a coronary surgeon.
Yeah, and I put up here one of the comment of Sarah Zivaco, a great I6 resident in Chicago. I'm in Chicago right now today, and she's very focused on coronaries and in the future of robotics, I would say. And I agree with Shazad what you just said. I take back 1 second, and I try to be provocative here, and I might wake up people on Saturday morning, but I think that all of this, when we talk about complete revascularization in cardiac surgery, we open a big Pandora box, and we don't really know what exactly we are talking. And particularly right now in an era of optimized medical therapy, that the medical therapy available today is so much different than the medical therapy of just 20 years ago when this study were done. Number two, I would say that in general, and please, the rest of the panel here, you have way more experience than I do, but in general, I would say that the era of bypass times 7 or bypass times 8 is gone. At the early stage of my career, when I was a resident in Italy, I was still having this perception that almost the most senior surgeon of my group were almost challenging themselves and competing of how good they were based on the number of bypass that they were doing. And I think that this type of culture is gone. But there was a time in which we were thinking that bypassing every 1 millimeter acute marginal has something to do with a good revascularization that you provided to the patient. And that definitely for sure still from patients when they say, "Oh, I had 6 bypass," they feel that it's so much better than their neighbor who just got 2 or 3 bypass. And I think this stuff are evolving in our own culture, probably rather than putting a vein on every millimeter bypass, that when now you can check your flow and you see that the contribution is less than 10 milliliter of blood per minute, and you know that the chance of that bypass to stay open in long term is very low. Using more multi-arterial bypass grafting, making sure that that patient is in optimal medical therapy after, has almost more important than this big concept of complete revascularization. Andre, can you take this concept and give me your 30,000 feet view on this complete revascularization in 2026? What is that?
Well, in coronary, there was a difference of 0.5 grafts between the two groups. So we look into that and say, where was it? What are the diagonals? The diagonals were grafted less frequently than off-pump and on-pump, but all the 3 main vessels, the rate of graft was identical. So is grafting a diagonal really important? We can just now, to be very controversial, I just want to let you know that in Canada, the more grafts you do, the more money you make. Interestingly, so in other countries, the more cases you do, the more money you make, and they do less grafts in those countries. So there's always a human factor in there. So so to me, the difference in number of grafts and off-pump and on-pump, it doesn't exist. I think it's a non-issue. Absolutely. Last point that I forgot initially is that when the 3 main trials were done, patients received only aspirin. There were no dual antiplatelet agent in those days. So obviously, off-pump patients should receive dual antiplatelet agents, and that improve the results. I have a colleague that's writing a paper on that right now. So we have to interpret these older trials. Well, it was a long time ago. So.
Completely agree. And Dr. Pascas, I give this question instead to you, and we are wrapping up, but I know that this one goes down the alley of your own heart. John, Jenny Perry is a friend and is a great surgeon who is dedicated to coronary, and she has been successfully started in Connecticut a robotic coronary program. And she has a very good point. Why the STS never added? Let's just put on aside this off pump and on pump, but just why we don't use a second arterial conduit as a metric for quality for assigning free star at the STS? Why grandma that is concerned about which surgeon in the city where she lives will operate on her husband and is looking online cannot have a tool like the starring system of the STS, making sure that she will be directed to choose the surgeon that can offer more multi-arterial bypass grafting for her loved one, for her husband, or whatever else. What is your concept here, Dr.
As
Pascas?
you know, I have been vocal in advocating for a star rating that incorporates a measure reflecting the adoption of multi-arterial grafting. I think it's very important that we do that. There's been reluctance to doing that because of, frankly, concern of pushing too many surgeons who are not confident or capable or comfortable doing double mammary grafting and pushing them towards adopting that. We also know that when the right mammary artery is used in a manner that leaves it tight, or taut, too short, or sometimes when it's anastomosed as a free graft to the aorta directly, the patency rates are not great. And so, it really matters how you use that second arterial graft. I think that if you're going to use a second arterial graft, which I encourage every surgeon to do for every patient, the first easy next step is a radial artery. And use that as you would use your best piece of vein, namely to anastomose to the second most important artery in the heart, whichever one you consider that to be. The STS is coming around and is becoming slowly more willing to nudge its membership towards better practice. And we've seen that just this past week with the adoption of measures of ablation for patients who have preoperative AFib. It's been known for a long time that ablating AFib at the time of surgery is good for patients. But now we have the beginning of monitoring of within the STS database to track the behavior of surgeons for patients who have preoperative AFib. I think we're beginning to see a change where the STS database and STS leadership is willing to be a little more active in nudging forward surgeons to change their practice in a way that conforms with good evidence for best outcomes for patients.
Fantastic. I go for the last comment and then we wrap it up. I think that this one is, Shahzad, tell us a little bit more. You were talking about training. David Verghese is in UK. And in this month in which I was changing job, actually, suddenly you spend a couple of weeks where you're not sewing anymore and your surgical soul start to itch. And David was very keen in sending me his training simulator, and it just got delivered to my own house, and I used it, and I was just while on vacation with my family, I was using some 7.0 and 8.0 like a good resident, sewing them just to maintain my skills in this in the weeks in between the jobs. And I think that That's another big missing opportunity. We always talk about advancing techniques of pump, robotic, multi-arterial, but we still teach residents in our operating room, and we have a very rudimental type of training system, something that for sure in aviation we don't see it anymore. People don't learn on a real flight. They learn on simulators for hours. So when we will start to convince companies that are interested in off pump to invest some times and dedication and training in training. I take AFib for instance. I think that out there are companies that really put themselves into the training of atrial fibrillation and created a culture of AFib, a concomitant surgical atrial fibrillation. When we will have someone that will take training to the next level for off pump, and how this training will look like?
Yeah, thanks, Gianluca. I think, interestingly, David and I worked on that simulator, so I'm glad that you've had a trial of the simulator, which is brilliant. What is interesting is that we recognize simulation quite early on. I was a quality assurance lead for training for the SSE in cardiothoracic surgery in the United Kingdom, and I was on this panel for about 6 years. And it took me almost 5 years to convince colleagues that the way forward is actually simulation. You want your trainees to have already done 2,000 anastomoses in a controlled, supervised setting before they are let loose on the patient in the operating room. I think that is the way forward. Obviously, the only way to encourage that would be if the societies ensure that simulation becomes a part of the curriculums. What we are very fortunate in the UK is that the first 2 years of our 7-year training program is actually the time where we can encourage our trainees to do simulation as a part of their training. So the society is trying to incorporate simulation in the curriculum, and I'm hoping that by 2030, hopefully every trainee in the United Kingdom would have had simulated training to perform an op-cab, coronary bypass procedure, a mitral repair, and perhaps an aortic valve and ascending aortic replacement in a simulated setting where they're going to be assessed and they're going to be signed off to perform the same procedures at a more advanced or senior level in OR. But I think the way forward is to teach in a simulated setting. I think it would make teaching op-cab much easier. It would also make teaching a much more safer and a much more productive activity. I think what I would be very reluctant to do is teach, which we have done up until now. I think a lot of us were brought up in an era where see one, do one, teach one was the mantra, and we've perhaps been brought up in that way. But I think in 2026, nobody should be coming to OR without having practice what they're going to be doing to the patient in a simulated setting. And I think we're very fortunate for quite a lot of procedures. We do have good quality simulators. I think in coronary surgery, Paul Sargent has spent a long time training people in a simulated setting. We've got people like Sargent whom we can use for developing a curriculum which should perhaps be endorsed by all the societies. And I think that would be the way forward, because I personally feel that training has to be enjoyable. Shouting and screaming at a resident when the LED is basically occluded and he's struggling to put a stitch is perhaps not the nice way to either train or good for the patient. So I think the buzzword in 2026 is definitely simulation. I think simulation is how we should be training everyone.
I completely agree. And Andre, I give you the microphone for the last taking home message. I take this question. So if you want to wrap up this conversation of an hour, give me your final taking home message. What we should have learned, and what do you think it's forward ahead of us? Where is off pump here in 2026, and where it will be in 2036, 10 years from now? Sorry, you're muted. I'm sorry. Go.
I'm okay now. Can you hear me? Yeah. It's more than off pump, but it's multiple arterial grafting. I think it's time for John to write a big editorial in ATS and call it High Surgical Intelligence. So I think, John, you're in the perfect position to tell the, people in the States and worldwide, being a coronary artery surgeon, there's a need for higher surgical intelligence. You need to think about what you're doing and why you're doing it and who is your patient. So that will be my final word for this meeting. So nice. It would be a nice paper, John.
Well, with that said, I want to say thank you for everybody who watches from so many different places, from North Carolina, Shai Rai, from Ecuador. We have people from Korea, Pakistan, US, Chicago, New York. I really want to say it's impressive how many people wants to spend an hour of their Saturday morning with us, and this tells you how many people are really out there willing to try to learn from us, from colleagues, from other people, and caring for their own patients that will be on an operating room on Monday morning. So I think that I've said that. I just want to thanks again. I finish with these last slides, remembering everybody that the 12th International Coronary Congress will be held in India, and we are waiting for all of you in New Delhi in November from the 20th to the 22nd. Please come and see us, and looking forward again for a new event very soon of this live talk, and will be next month, very in a very timely manner. So with that said, thank you again, and looking forward for connecting with you soon. Bye.
All the best. Have a great day.